science is concerned, the most sound as far as research is concerned, as far as reproducibility of the results is concerned, as far as documentation in the form of textbooks or references, publications are concerned. It is the allopathy which tops the most. Probably the funding for research and other things are also maximum in allopathy as compared to other disciplines of medicine. What we can do in all these is we can replace what is not there in the human body, or what we can do is control the symptoms. We can prevent certain, and that is because of continuous innovations. But how innovations can happen? This is the quotation from Albert Einstein, that imagination is more important than knowledge. Anything that exists in the world today has to exist in somebody's mind first. He has to decide what should be done next for the betterment. As far as communicable diseases are concerned, I'm going to touch the burden of it, infection and inflammation with practicing doctors. We focus at treating in death rate is also around 2 to 3%, and the morbidity is to a tune of 10 to 15%, mainly in the form of persistent arthralgia and myalgia. Lack of effective second one is less used, third and fourth are hardly used. The new biomarkers are like lipopolysaccharide binding protein, LBP. Another is procalcitonin. And third is exhaled volatile organic compounds, VOCs. These things are comparatively new as far as biomarkers are concerned. What is bacterial infections? Patients with bacterial infections have higher serum procalcitonin levels than those with non-bacterial infections, including viral infections. And so serum concentrations in healthy individuals is less than 0.1 nanogram per ml. And this is the algorithm of procalcitonin published recently in this year only, July 2013, septic shock. So ranging from must not be used, should be used, should not be used, should be used, and must be used. Antibacterial therapy, indicated development, tuberculosis skin test, BCG vaccine, and solid culture medium to diagnose or detect mycobacterium tuberculosis. As far as medicines are concerned, streptomycin was discovered. That was the first ATTB drug by Waxman in 1943-44, and later on, till 1963, various medicines which we have been using middle of the 8th decade last century. During that century, even TB and HIV co-infection also started initially, and now it has become a monster. In 2010, introduction of Gene Expert, which Dr. Kadiyar has touched upon, it is a very inconsistent and imprecise estimates of sensitivity and specificity. High proportions of false positive as well as false negative results are there. Use discouraged by WHO as well as Government of India and RNTCP. Health Ministry and DCGI have tests are in the form of liquid culture, which is BACTEC, available in private and commercial growth-based culture system. Another is automated detection and MDR plus and MDR plus SL tests. These are also available in India. The benefits are that it can be performed from patient specimen, maybe sputum, maybe urine, CSF, pleural fluid, stages. If we look at the vaccines for infectious diseases, right now 137 vaccines are in the process of being developed. HIV, influenza, TB, dengue and malaria. We wish that all these vaccines and a few more, total 11 candidate vaccines are being evaluated today by various agencies in government permission, out of which probably this mycobacterium vacci, which is European vaccine, is in years earlier, then it got reduced to 6 to 9 months. But if we can treat this disease in less than 6 months' time, maybe 4 months or 3 months or even 1 month, it would be desirable. One would stick to the regular treatment, and from community point of view also it would be very useful. Different mechanism of action. A new drug should have little different mechanism of action so that human body bioavailability of conventional rifampicin 450 is equal to boosted rifampicin, which is conventional rifampicin 200 mg plus 10 mg fibrin. This boosted rifampicin is time tested, confirmed and approved by DCGI after animal studies, pharmacological studies, dose titration studies, and a classical, well-structured, double-blind, clinical, multicentric study, which was organized by DCGI, and it was a multicentric. It has taken around 15 years' time and millions of rupees, I would say billions of rupees, to develop this drug. It was made available first and so far only in India than anywhere else in the world. So the concept of this combination is indigenous. The institution behind this is RRL Jammu, which is a government institution. Some innovations in this dengue fever eradication. It is Professor Luke Alfie. Female mosquitoes will die. Before death, they give birth to newer offsprings. But if newer offsprings are born with genetically modified males, then these new offsprings will not survive and not grow into adults. So gradually, the whole mosquito breed should be abolished. Several dengue vaccines are being developed. Many of them are DNA vaccines, and one is the recombinant vaccine, and most of them are in the clinic, which is then put into the device, and the results are available within an hour. This is a very quick method, not only to diagnose HIV, but also to diagnose AIDS, full-blown AIDS. What is the future of communicable diseases? A number of promising new diagnostic tests, vaccines, and medicines are under development. These innovations will help us in fighting communicable diseases promptly and hopefully more effectively. But the marathon must go on. If you can't fly, run. If you can't run, walk. If you can't walk, crawl. But whatever you do, keep on moving. So we have to continue this marathon of research for the betterment of human suffering alleviation. Thank you. That is one way. Another way is to treat MDR cases very effectively, cost effectively, and with tolerable medicines. Whatever medicines are available today, as far as MDR medicines are concerned, many of them, I would say almost all of them are very toxic. It's a lengthy treatment, and defaultation is almost the rule in MDR.
And suppose a child has tuberculosis, then what do we do?
This gene expert is useful if sputum is not available. Either can induce sputum, we can take gastric samples and do it, or in extrapulmonary cases, we can take CSF. If it is CNS tuberculosis, pleural fluid in pleural effusions, joint fluid as far as it is arthralgia, or ascites fluid if it is tuberous peritonitis. But in other cases where body fluid is not available, we can take the biopsy, and there is a process specific gene expert is being done, and that will be useful, particularly in pediatric and geriatric and critical illnesses. Very useful.
Yeah, tuberculosis.
Correct.
Query tuberculosis.
Correct.
So in that case, would this CSF gene expert help?
If it is positive, if the patient is very critically ill, and if you consider that it is likely to be active, then it is better to treat the patient.
Then you don't have new drugs. And what we learned, that you are going to reduce the treatment duration. Well, you are helpless and you are reducing treatment duration. Why? That the treatment which was designed in R&D-CP, I always condemned it. That this is a useless treatment which has been thrust on us. And when you talk of human lives of TB patients, I think the human right of every TB patient who goes under treatment R&D-CP is harmed. The first National Tuberculosis Control Program, which was launched somewhere in the 70s, 60s, 70s, gave rise in ironage resistance. And in today's MDR TB that we are seeing, I strongly say, is the result of the new revised R&D-CP program. The WHO has come out with new guidelines, but the Indian government doesn't want to listen to that. They want to continue with the same intermittent regimen, which is not used anywhere in the world. Let me tell you, intermittent treatment, which is the treatment in R&D-CP, is not used anywhere in the world except India, not even in Pakistan and Bangladesh. So we are unfortunate.
They are worried about population. They want to reduce population.
They are not worried about population.
Like this.
We always condemned it, but they were used to the extent that 785 million rupees per year was spent on diagnostic tests of IgG, IgA and IgM as far as tuberculosis is concerned. 785 million rupees spent on diagnosis, and how much money would have been spent on treatment of TB, a wrong treatment given, we cannot estimate. Now there is another test, what is called as TB gold test. It's another version of IgA, IgG and IgM. And now since that is not available, physicians, I would say, which is almost, the WHO has come out with recommendations against this test also, that they should not be used for the diagnosis of tuberculosis. But unfortunately, our colleagues in our country are using this test as making it the basis of diagnosis of tuberculosis, which is very wrong. And I strongly condemn it, and it should never be used as the basis of diagnosis. It should only help to some extent, along with other evidences in making diagnosis, but not as a single test, because it is so expensive. Just costs around anywhere from 2,500 to 3,500 rupees, and the patient thinks that this is the ultimate test which has been done in tuberculosis, and the treatment is started. So this is something which is fallacious, which has been condemned by scientific forums, which has been condemned by WHO, and the Indian government also has come out with recommendations that it should not be used.
All doses are not observed. It is for the first initial intensive phase only that these doses need to be observed, that they are supposed to be observed, which is not being done in the country. That is number one. Number two, in the continuation phase, 1 out of 3 doses in a week needs to be observed. So even if everything goes well,
In cardiology we have a CT angiogram.
yeah,
We cannot perform bypass surgery on the advice of CT. We have to do conventional angiogram,
which is gold standard.
which is gold standard. But a unique utilization of CT angiogram has come.
It is most
And that is the unique utilization of CT coronary angio is negative predictive value. If your CT angio is normal, 99 to 100% you have no coronary angio. This is very good news.
So
Do you have any such test? Do you have any such test in the field of tuberculosis? That if this test is negative, tuberculosis is 100% not existing. Do you have any?
so far not.
Very unfortunate.
Unfortunately. Yes, we met WHO officials also. We have met Bill Gates Foundation also. And he has approached government of India also. And he has been able to convince regarding further studies on large population, and probably in India, 2 states, the government has agreed probably to study this in large number of patients.
Are you using it this drug?
I am using it left and right in my
And what is your experience?
It's very good, very good. Almost
Additional dosage. I'm still going on with that, but maybe if we have got some more data available which can prove that yes, it is, because tuberculosis is a disease where you do not only want cure, you do not want resistance to emerge. That's the biggest problem. And relapses occurring. So if the drug is not acting, it's not only drug not acting, but it is simultaneously creating more drug resistance and relapses occurring. So that is one thing which has to be taken into account.
That was the point of concern. Just physicians are befooling patients. And treating this disease.
neurological, yeah, even in neurological cases, I have found equally good results. I have used it extensively in CNS tuberculosis, GI tuberculosis, tuberculosis of mediastinal glands also, equally good results. Unfortunately, there is no published data of relapse. That is number one. But as far as efficacy is concerned, that we can judge clinically also, radiologically also, and wherever possible, by there is no sign of relapse, then it would say that it is a very good medicine. Unfortunately, there is no data available.
I feel the Cadila people should take up this job, that the follow-up should be done,
Yes.
and that's why
Cadila. It is actually been researched by RRL Jammu, which is a government body, further accredited by CSIR. Our founder chairman, Shri Risorine Modi, has actually went for the public and private partnership with CSIR and RRL Jammu and did the phase 2, phase 3, phase 4 trials, and then with the permission after submitting the cytochrome P450 to the body, as well as the levels of PGP, because of which we are able to increase the bioavailability of rifampicin. And as been rightly said by Dr. Patel, that we are not on with a large population, and the data is yet to be come on 2014. By December, I think the studies will be available. We are already in talks with many of
Positives and negatives, as diagnostic, less than 5%, as the data says, both false positive and false negative is less than 5%. The confusion would be, as I also uttered regarding that, regarding the mixed infections. Otherwise, if it is pure bacterial or pure viral or pure any other parasitical organism, then this data is very authentic, almost 95% sensitive. Only thing that we have to start using it more and more. If any good laboratory does it of chlorine, it is a good test. I have done it in more than 20 patients by now.
सर मैं ये जानना चाहता हूँ कि थेराप्यूटिक ट्रायल ट्यूबरकुलोसिस
almost all other diseases, and if the patient is suffering, then he has a right to get anti-TB. That is what I do in my private practice. But if you ask any academician, then maybe myself or Dr. Cadila, they would say that there is no role of therapeutic trial unless you find out some evidence of tuberculosis. If there is no evidence of tuberculosis, and if the symptoms are
Just a minute. And therapeutic trial should never be given with those anti-TB drugs which have got antibiotic effect as well, including rifampicin, including all the newer anti-TB drugs. Most of them have got antibacterial effects, but you never know whether the response that you get with the therapeutic trial is on account of anti-TB effect of the treatment or is it on account of antibacterial effect. So that is a big caution that it should be the last thing to be done, and if it has to be done, it has to be done with those drugs which have got no antibacterial activity.
Any medicine to any patient who is living human being, unless this has been shown in large clinical trials, double-blind trials, randomized trials, that the basis of writing a drug to human being is scientifically, logically, is a large clinical trial. There is no large clinical trial. Why do you talk of this condition? There is no sense.
In the same patients it was studied, and it was found that the levels with Risorine were higher than even 600 milligrams.
This should be proved in a large trial.
Trial was started in 1995, and my center was one of those three centers. That time, the study of relapse was not included, and that is why it has not been done. I would admit that it should have been done. If it is done today, it should have been done. But the number is decided by the biostatistician of this year. It was not decided by Cadila. That is number one. There are many clinical trials wherein the clinical trial on 20 patients have been accepted and published, and according to that it is done. But we certainly still believe that it should be a multicentric large trial. No doubt about it. End of story.